So again, welcome to, this is our 2021 virtual family conference. Today is our very first session kicking off what's going to be a full week of presentations. And I'm very excited to have you here today alongside Dr. Christian Schaaf. Dr. Schaaf is both a MD and a PhD whose research focuses on the genetics of neurodevelopmental and neuropsychiatric disorders. You likely know Christian as the person who first identified schaaf-yang and continues to drive research in that area so that we can better understand and treat the system. So Christian, I'm sure if we were together today in person, there would be a huge round of applause for you, but the floor is now yours.
Well, thank you, Susan. Thank you, everybody, for joining tonight. It's 6 o'clock in the evening in Germany. I would love to meet you all in person, but hopefully, that can happen again next year at the FPWR conference in Chicago. Let me share my screen. I wanted to give you an update on both our research and also our current perception of the clinical phenotypes and care for individuals with schaaf-yang syndrome. I'm presenting from my hometown where I went to medical school, and then after 13 years in the United States, returned in 2019. This is Heidelberg in Germany, old university town. University was founded in 1386, and I'm directing the Institute of Human Genetics here at the University Hospital of Heidelberg. And one of the nice aspects of coming back is that I'm also getting in touch with many more of the European families with schaaf-yang syndrome who I had been in touch via email for years. So how did this all get started? Many of you know the story and know that it kind of traces back to 2012 and 2013. In 2012, I met the first individual who then turned out to have a MAGEL2 mutation and a condition that was later named schaaf-yang syndrome. That was Donnie, who presented to my clinic at Texas Children's Hospital with autism spectrum disorder. In 2013, we reported Donnie along with 3 other individuals with truncating mutations in MAGEL2. And we basically stated that individuals with those mutations in the MAGEL2 gene have a clinical manifestation that is quite similar to Prader-Willi syndrome, and in addition has a very high prevalence of autism spectrum disorder. MAGEL2 is one of the genes within the Prader-Willi syndrome domain. So in Prader-Willi syndrome, this domain is typically missing or inactivated because the paternal copy of this segment is missing. And within that piece of chromosome material on chromosome 15, there are a couple of protein coding genes and then also smaller RNA genes. And one of those protein coding genes within the region is MAGEL2. Again, this is kind of genetically an unusual domain because even though we typically do have 2 copies of chromosome 15, only one of the 2 copies is actually active. It is the one that we inherited from our dad. That's the active chromosome segment 15, where MAGEL2 and all the other genes within that region are expressed. The copy that we get from our mom is inactivated, or we say imprinted. So it kind of is labeled with kind of special marks that lock the information away, and the maternal copy is not used to generate any protein within that region. Now, in the early days, we discussed the relationship of schaaf-yang syndrome and Prader-Willi syndrome, and we highlighted that there's a lot of overlap. We felt that the overlap was in particular affecting the muscle tone. Those kids had low muscle tone. They have feeding difficulties, which is also a typical feature of Prader-Willi syndrome. A lot of those kids are tube fed. And then as they get older, parents and physicians notice that there are developmental delays, and ultimately leads to intellectual disability, which in most of the cases is moderate or mild intellectual disability. Also, hypogonadism is noted. It's easier to see in the boys because they often have undescended testicles and frequently small penises. But then there were also differences, things that we frequently see in Prader-Willi, and we felt that they weren't present in schaaf-yang quite as often, especially the excessive need to constantly eat. We call that hyperphagia, so overeating, which leads to severe obesity whenever it goes untreated. And then on the other hand, in schaaf-yang syndrome, we saw some features that are not that often seen in Prader-Willi, in particular, very high prevalence of autism spectrum disorder, affecting almost 80% of all kids with schaaf-yang syndrome. And then one of the typical features that's frequently present even at the time of birth, which is the contractures of the joints, most frequently affecting the small finger joints. Now, it all started with 4 individuals reported at the end of 2013, but we continue to get in touch with many new families and individuals who are affected. It's getting harder and harder to keep track, but at this point, we're in touch with more than 250 families. The last time we reported the entire case series, that was in 2018. I think at that time we were in touch with approximately 120 individuals, and that was all summarized in a publication by one of my students, John McCarthy, published in the American Journal of Medical Genetics. There's one hotspot within the gene, right in the middle of the gene, at nucleotide 1996. That is by far the most common mutation. When you have an additional letter within that region, an additional C, it leads to typical schaaf-yang syndrome. Almost half of all cases have that additional C in that spot. But then there are also individuals who lack one copy of a C, the nucleotide cytosine, and that actually causes a very severe manifestation, one of the most severe manifestations of schaaf-yang syndrome, which unfortunately frequently leads to pre or perinatal death. Now, what you see here is that we are in touch with families. Families who have multiple affected individuals with schaaf-yang syndrome. That is kind of unusual for Prader-Willi syndrome. In Prader-Willi syndrome, typically it's isolated cases, only one affected individual within the family, and then it's not passed on from one generation to the next. But in schaaf-yang syndrome, it's different because it affects only, most frequently just one letter within the MAGEL2 gene. And because of the imprinting, because the maternal copy is not used, it can actually be inherited and kind of passed on in the maternal line of the family. As long as it's passed on from mothers to their children, nobody will be affected clinically. Only when a dad passes on the mutation to his children, then they will manifest the clinical features of schaaf-yang syndrome. Now, what are those clinical features? Some of them I already listed. Let's go through them, kind of also looking at them, how they evolve by age. So typically those kids, they manifest early. It can manifest prenatally, but at the latest, at the time of birth, the physician or the nurse will notice that something is different about those children. What's typically noticed right in the neonatal period is the very low muscle tone. These are considered floppy children, floppy infants. And because of the hypotonia and also kind of the incoordination of the musculature in the throat, they have feeding difficulties and they gag and they spit up a lot. Many kids will require feeding tubes to be inserted, at least for a while. Some of them, have those issues in the long term, and they will need a G button to be placed so that nutrition can be secured for them. Because of the low muscle tone, the kids also don't move their extremities and joints as much as they should, which we think is one of the main reasons why they develop contractures. So because in utero, they don't move their joints very much, and they don't move their hands, they don't open and close their hands as much, they end up having contractures, especially affecting the small finger joints. Many of the boys have undescended testicles, and then again, as they get older, we notice that they reach their developmental milestones later than their peers. There are additional common features of schaaf-yang syndrome, and those include sleep apnea, which can be obstructive, central, or combined. It affects almost or just around 3/4 of all children with schaaf-yang syndrome, and I highly recommend that every child at the time of diagnosis should get a sleep study. A lot of the kids have respiratory problems. More than half of them have a history of intubation at least once, typically in the neonatal period. And some of them are then really difficult to wean off the respiration machine, and they may require tracheostomy also to secure the airway, especially when they have issues with gagging and aspiration, etc. Almost uniformly, kids with schaaf-yang syndrome have feeding difficulties, including dysphagia, so difficulty of coordinating the swallowing process, and 3/4 of all kids require tube feeding at some point. These are the hands of children with schaaf-yang syndrome, and you see a lot of similarities here. This can really be a diagnostic clue in the newborn nursery. They have tapering of the fingers, so the fingers kind of become thinner towards the end, and they have the contractures. Sometimes it's so difficult and so severe that kids with schaaf-yang syndrome almost have kind of clenched hands, and they can't really open up their hands adequately. So some of these kids require surgery, kind of like a tendon release surgery, so that they are able to open up, and that it can allow for an opposing thumb. But in many of the cases, it's not quite that severe, and physical therapy and occupational therapy done diligently over weeks and months will help to open up those hands and for the hands to become more functional. There are more issues that affect the bones. We do know that there's a decrease in bone mineral density. We did a study at Texas Children's Hospital where we were able to show that both in the spine, but also and more severely in the hip, there's decreased bone mineral density, kind of like osteoporosis. And it may be an intrinsic kind of abnormality of the bone with the function of the osteoblasts and the osteoclasts, the cells that build up the bone. But in addition, because the kids, reach their developmental milestones late, and they don't move as much, so they start walking later, they don't bear weight as much on their legs, which then will lead to kind of further worsening of the osteoporosis. So you can see that here, it's actually worse in the hips than in the spine. The spine also shows scoliosis in a lot of kids, so I do recommend to keep an eye on that during physical examinations, while child checks, and when in doubt to do x-rays of the spine, and when there is scoliosis to kind of follow up on that over time. Some of the kids unfortunately have scoliosis that's so severe that it requires surgery, because it can actually kind of lead to compression of the lungs and cause pain and disability. Now, for several years, we didn't know much about adults with schaaf-yang syndrome, and this is a question that a lot of you have asked, what does the future bring? Like, will little Johnny be able to live independently? Will this get better over time? Will it get worse? What will his adult life look like? We published a study of some individuals last year. This was headed by Dr. Marbach, who is a young resident in my team, who is specializing in schaaf-yang syndrome here at the University of Heidelberg. And there are a couple of interesting things when you look at the adult phenotype of schaaf-yang syndrome. One, very positive aspect is that a lot of the complications and the medical complexity that you see during the neonatal period and infancy seems to go away and get better. I always feel that the first 2 years of a child with schaaf-yang syndrome are the most challenging for the family and for the child. That is the time when a lot of time is spent in the hospital, a lot of readmissions, a lot of airway issues, apnea, etc., etc. In some ways, the kids become more stable and easier to manage as they get older. So a lot of the families who have children who are now in their teenage or adult years will say, oh, it has gotten so much easier. A lot of kids come off tracheostomy, a lot of kids come off the feeding tube, and they do reach their milestones eventually. They will start talking, they will start walking, and life gets a little better. On the other hand, and that may be unfortunate, some additional manifestations seem to arise over time. And when initially in 2013 we felt that the obesity was not an issue in schaaf-yang syndrome, this may not entirely be true when we look at adult individuals with schaaf-yang syndrome, because as they get older, the hyperphagia, the overeating, and also the weight gain becomes more of an issue. So it appears, based on our limited experience at this time, that a lot of the adult individuals with schaaf-yang are overweight, and some of them are actually obese, and it becomes somewhat more challenging to manage their weights. So you can see that here, BMIs in the 30s, in the 40s, sometimes in the 50s. Overeating is an issue, food-seeking behavior is an issue. Sleep apnea stays an issue, so sleep studies should be done, repeatedly. Obviously, when people get overweight, sleep apnea can worsen. You know that from people, without schaaf-yang syndrome who are obese, they tend to snore and develop sleep apnea when they're older. And then also some of the things that you already experience, like the alterations in circadian rhythm, the abnormal sleep cycle, excessive sleeping during the day, and daytime fatigue. Behavior issues, have been of interest, and we have summarized them in these adult individuals with schaaf-yang syndrome. They're generally underactive, so they're not particularly interested in physical exercise. And then some behavioral issues that can cause tensions also within the family, such as stubbornness, temper tantrums. Aggression is not a huge issue, only some individuals show aggression. But kind of like a deceitfulness is reported in some of these individuals, stealing, etc. And then more psychiatric phenotypes like manic episodes, depressive behaviors, high level of anxiety, social withdrawal, and a restriction of interest. The restriction of interest probably going along with the autism spectrum disorder. So while medically, some things get better, other things like behavioral issues may become more of an issue. Some of that may just be related to them getting older. I mean, we know that from our neurotypical teenage kids that some of the things that I listed here become an issue when our kids go through puberty and get older. But it's certainly something we need to keep an eye on. Okay, so in 2013, this is what it looked like for us, how we conceptualized the clinical manifestations of Prader-Willi and schaaf-yang. This year, 2021, I would actually say there are not that many Prader-Willi typical features that are not seen in schaaf-yang syndrome. So this kind of highlights the close relationship of these conditions. It's a molecular and genetic relationship, but it's also a clinical relationship. Some things are still on the side of schaaf-yang, including the very high prevalence of autism, the contractures, and also when we look at the cognitive abilities, it seems that at least a subset of individuals with schaaf-yang syndrome are more cognitively impaired than what we typically see in Prader-Willi syndrome. So this remains an open question that we're trying to answer, but it appears that schaaf-yang syndrome in some ways is a more severe condition than Prader-Willi syndrome. Now, Prader-Willi syndrome has been known since the 1950s, and a lot of investigation and research has gone into that, and therapeutic pathways have been developed. So what can we as a schaaf-yang community learn from Prader-Willi syndrome research, and what can we translate to schaaf-yang? One thing that seemed very obvious and that we really wanted to look at from the beginning was the growth hormone deficiency. So growth hormone deficiency is known to be part of the phenotype of Prader-Willi syndrome, and recombinant growth hormone has been approved as a treatment for Prader-Willi by the FDA since 2000. So at Texas Children's Hospital, we performed a study where we looked at the hormonal levels of individuals with schaaf-yang syndrome. And fair enough, we found that we found evidence that a lot of kids with schaaf-yang syndrome appear to have growth hormone deficiency, especially when looking at the IGF-1 levels on the upper panel of this graph here. So I mentioned growth hormone being an approved therapy for Prader-Willi since 2000, and it has beneficial effects that go well beyond boosting the linear growth. I would actually argue that some of the other effects are much more important. So it's the kids grow better, but also body composition changes such that adipose tissue is decreased and lean muscle mass is increased. And the increase of lean muscle mass and the loss of adipose tissue leads to more strength, more endurance, more exercise tolerance, and gains also in motor development. It also has metabolic effects that are very positive, and it may even affect cognition in some ways. There's some evidence from Prader-Willi research suggesting that there may be benefits in regards of cognitive function. So as we learned about that, some of the kids with schaaf-yang syndrome were started on recombinant growth hormone as an off-label use. This is Trinity from Kansas. One of the very first patients with schaaf-yang syndrome, and I've had the pleasure to meet Trinity and her family a few times. They've also been at the schaaf-yang family conference as part of the FPWR conference in Indianapolis a couple of years ago. So Trinity was started on recombinant growth hormone, and there are only a few months between these two pictures, and you can see the tremendous effect it has had. What's most evident here is the changes of body composition, the decrease in adipose tissue, but it has also had an effect on her body composition, her stature, her ability to do things, her endurance. So only after she was started on recombinant growth hormone, she was starting to walk long distances without complaining and the need to sit down constantly. She started riding a tricycle, motor coordination, strength, etc. All of that got better. But those were just case reports and single individuals that reported back to us. So we felt the need to look at that a little more systematically. And Niels Hebach, who is a medical student here in my team in Heidelberg, and again, Felix Marbach, the physician from our team, and also my new research coordinator, Pilar Caro, who many of you have been in touch with, started to kind of get back in touch with you and collect information retrospectively about the use of growth hormone in children with schaaf-yang syndrome. And this study was published just a couple of months ago in the journal Clinical Genetics. So we present data of 26 individuals with schaaf-yang syndrome. And among those 26, there were 14 on recombinant growth hormone and 12 individuals without treatment with recombinant growth hormone. And what you can see here in these graphs on the right, especially here, I hope you can see my mouse, is that recombinant growth hormone, as expected, has a positive effect on longitudinal growth. Also, it has a positive effect on the body mass index. So here in these graphs, these are box plots. These are the treated individuals. You see time after treatment starts. So the red box is at time point 0, and then 3 and 6 months after treatment with recombinant growth hormone, the BMI goes down. And here on the right, you see the change in BMI score, and all of that is statistically significant. So positive effects on growth, decrease in BMI, and what does that do in regards of like function and ability? You see this was assessed by a 5-point Likert scale. Which effect does the recombinant growth hormone therapy have on strength and stamina? And all of the families report positive effects, so moderate to strong increase in strength and stamina in all of the families whose children were on recombinant growth hormone. How satisfied were you with the treatment? A few of you had neutral feelings about it. More were satisfied, and by far the most were very satisfied with the treatment. There are also side effects of recombinant growth hormone. So every child should have a sleep study before being started on recombinant growth hormone. And it can have negative effects, and it can worsen the sleep apnea. So I think there were actually 2 children within the cohort whose sleep apnea worsened after they were started on recombinant growth hormone. So I showed you, that there are definitely things, and we do need to kind of keep having an eye on the newest developments of Prader-Willi research, because much of that may be relevant also for children with schaaf-yang syndrome. But then in parallel, we, my group and others, have done research more focused on MAGEL2 and schaaf-yang syndrome, and that yet again may have implications for Prader-Willi syndrome as well. So we came to learn that in neurons of individuals with schaaf-yang syndrome, and also in neurons or in the brain of the mouse that is missing the MAGEL2 gene, there are alterations in how these cells communicate, and there are alterations in how signals are transmitted within the cell. In particular, we learned that there's an upregulation of the so-called mTOR pathway. mTOR is a protein, and actually the mTOR complex, a complex of proteins that has multiple functions within the cell and ultimately affects lipid synthesis, protein synthesis, growth and proliferation, but also the recycling and degradation of proteins. And mTOR is upregulated in those neurons. And that is very exciting because we know of a medication, that's Rapamycin, which can inhibit mTOR. In fact, the name mTOR comes from rapamycin because TOR stands for target of rapamycin. So when mTOR is up and you give rapamycin, mTOR should come down again. So it was logical to look at whether a treatment with rapamycin may help to compensate those alterations. How do we do that? So this is where you, the families, come in again. And this really shows that most of what we do, we couldn't do without you. I mean, without all of you, I would have never discovered schaaf-yang syndrome. Without all of you, I would not have learned the things that I know about schaaf-yang syndrome. And without the generous donation of skin biopsies of several children with schaaf-yang syndrome who have been so brave to come to our clinic and allow me to do a skin biopsy, we would never have gotten to the point to understand what's going on in the neurons. So how do we get from skin to neurons? We culture the skin cells in a dish in the laboratory and establish a fibroblast culture. And then those fibroblasts can be reprogrammed. So we kind of move back in development or evolution, and we reprogram them to become stem cells again. And then when they stem cells, they have a lot of potential and they can be differentiated into all different kinds of cells, heart cells, brain cells, liver cells. They're not omnipotent, so they can't become a individual again, kind of entire individual, but they're pluripotent, so they can be developed into various types of tissues and cells. So we stimulate them and we trigger them into a particular path because we want them to become brain cells. So we make neurons from the stem cells because we feel that most of what we see in regards of clinical manifestations relates to the brain. So we want to study how the brain works of individuals with schaaf-yang syndrome. And so when we differentiate those stem cells into neurons, we realize, and I won't go into all the detail, but just to summarize, we realize that the neurons look differently, and the branching of the dendrites of the neurons looks differently and is impaired. But when we treat those neurons with rapamycin, then the branching becomes normal again, and they look much more like normal neurons, like the neurons of individuals who are not affected with schaaf-yang syndrome. This is a study that one of my PhD students in Houston, Emmeline Crutcher, conducted, and that was published in 2019. Now, this was based on schaaf-yang syndrome, and at this point in time, we're also doing the same studies on neurons with Prader-Willi syndrome, because we want to find out if this holds true for Prader-Willi syndrome in general as well, but that's still ongoing. But what's even more interesting to you is, does this also work in a living organism? I mean, it's nice to see in a dish that we can kind of, treat those neurons and make those neurons look normal again. But what does that do to a living organism? Like if you give rapamycin over a period of time, does that improve clinical symptoms? Before we go into human individuals, we wanted to look at mice. And we do have a mouse that is lacking the MAGEL2 gene. So that is our model, our mouse model for schaaf-yang syndrome. And those mice, we can do all different kinds of tests with them. But one of the tests that we do with them is we put them on a treadmill. It's kind of a little itty bitty treadmill, a mouse treadmill. And we let them walk on the treadmill. And, when we compare them to their siblings who do not have schaaf-yang syndrome, we realize that the schaaf-yang mice, they don't want to walk as much. They just don't have the strength and the endurance, and kind of they slip off the treadmill much earlier than their sibling brothers and sisters. And they can't walk such a long distance. You see that here. So the dark blue box is the distance that the healthy mice travel. So you can see they travel like 200, 250 meters. The light blue are the schaaf-yang mice. They can only travel 100 to 120 meters. So just about half of what their siblings can do. And then, how much time can they spend before they get exhausted? So you see, they also spend like twice or 3 times as much on the treadmill before they get exhausted. And what happens if we treat those mice with rapamycin? This is a study that is actually funded by FPWR. And I'm sure that, this includes a lot of money that you all have raised during various fundraisers such as the I Got a Guy Sausage Festival in Chicago and many of the other fundraisers. I know many of you have contributed and have donated to FPWR, and this is in part where your money goes. So FPWR has funded this study, and we have been able to treat those mice with rapamycin, and this is what happens. So the red box are the healthy mice when you give rapamycin to them. We have to do it in that way because at the time that we do the test, we are entirely blinded to which mouse has the mutation and which mouse doesn't. And we are also entirely blinded whether the mouse received rapamycin or whether the mouse received a placebo. So the person who does the treadmill experiment is a different person than the person who gives the injections. And you can see the red box is the healthy mice with rapamycin, and the yellow box is the schaaf-yang mice with rapamycin. And you can see it goes way up. So once you treat them with rapamycin, and these mice have been treated with rapamycin over several weeks, their ability and their performance on the treadmill improves much. In fact, it gets very close to the ability of the healthy mice. This is true for the distance traveled, and is also true for the exhaustion time. Comes way up and is almost indistinguishable from their brothers and sisters who do not have the mutation. So this is very exciting. I mean, it's still very preliminary. The studies are still ongoing. We are looking at other tests to kind of recapitulate that and see if it also has an effect on other phenotypes, some of which are related to autism and speech. But hopefully it will hold up. And once we publish this, we will need to get a discussion started about when is prime time for humans to start clinical trials and treat children with schaaf-yang syndrome with rapamycin to see whether their motor abilities and maybe other functions as well improve when they're given rapamycin. The good thing about rapamycin is that it's already an FDA approved medication, and some of the rapamycin analog medications are also FDA approved, and they currently used for various indications, including some neurodevelopmental disorders such as tuberous sclerosis, where mTOR is also upregulated and it leads to epilepsy in those individuals. And when they're given rapamycin, it can treat the epilepsy really, really well. So I'm coming to a close, and I want to summarize what I've talked about before I look forward to your questions. I tried to show you that Prader-Willi syndrome and schaaf-yang syndrome are both molecularly and clinically related. I also showed you that we have learned that the schaaf-yang phenotype may actually be more similar to Prader-Willi than initially thought. I showed you that we can learn from the Prader-Willi community, and we have proven that recombinant growth hormone is beneficial for schaaf-yang syndrome as well. So in every child with schaaf-yang syndrome, you should get into a discussion with your pediatric endocrinologist and investigate whether your child may be a candidate for recombinant growth hormone therapy. And then lastly, I showed you some of the ongoing investigations of mTOR signaling and how we can treat that with rapamycin and what that may mean for schaaf-yang syndrome and Prader-Willi syndrome in the long run. So with that, I will close, but not without thanking the people who have been involved, both my team in Houston and my team in Heidelberg. I wanted to thank FPWR for the generous support over the years, and most importantly, all of you who have really contributed to our research, and your children who continue to be the inspiration for everything that we do every day in the lab and in the clinic here. So thank you all, and I look forward to your questions.
Thank you so much, Dr. Schaaf. It was really great to hear some of the evidence that you have for growth hormone. I know that we have some questions in regards to access to that. Before I give you that question, however, I just want to remind everyone that You can submit your questions through the Q&A. It's located on your Zoom panel. And if you have commentary that you would like to add to the discussion, please feel free to use the chat. The chat's open to everyone. So as we're talking about growth hormone here, if you have gotten it prescribed for your child, perhaps you would like to use the chat to explain how you were able to do that. Dr. Schaaf, the question is in regards to getting access to growth hormone and getting insurance to cover it. This parent said that even with a letter that you provided, the insurance is still denying their request. Do you have any suggestions for how they can access growth hormone?
Yes, it is challenging because it is not FDA approved for schaaf-yang syndrome. I mean, this is a long battle. This is not a sprint, it's a marathon. To get there, it has taken the Prader-Willi community many, many years to get FDA approval for Prader-Willi, and we're only 7 or 8 years into knowing schaaf-yang to exist as a condition. But the first step is to get in touch with a pediatric endocrinologist, talk to them. I know that some of the kids that we've studied, they got on growth hormone just because they had short stature and no test was done whatsoever. They were just started on growth hormone. Now, if you can't get it approved through your insurance company, get in touch with us. We're happy to write a letter, and in many cases, the letter has helped. Now, up until a few months ago, we only had the letter, and it was just my word kind of saying, I think it helps. Now we have a publication out, which really changes, the perspective. I think if you were denied before May and without submitting the publication, you should try again and kind of, send a copy of our publication along with your inquiry, and that may help. But it may still not be enough. So what else can you do? You may have to go the other route, and that is you may have to go through showing that there is an actual growth hormone deficiency, which, when you look at the hormones, we do see the growth hormone deficiency in many children with schaaf-yang, but not in all. And I think that's true for Prader-Willi also. And we know that even if you can't prove a growth hormone deficiency to exist on a hormonal level, the kid may still benefit from recombinant growth hormone because it still has an effect that it may actually go beyond, what's natural, but it may still have an effect on body composition and muscle strength. But if the letters and the publication and all the kind of nicely asking doesn't help, then maybe try to look at IGF-1, IGF-BP3 levels, and more formally, the gold standard to show growth hormone deficiency is a stimulation test, where the kid has to stay in the hospital overnight and they get injected with a hormone, and then they measure hormones at certain time points, and they can prove in some cases that there's a formal deficiency of growth hormone in the body. Now, when that's the case, then every child will qualify for therapy with recombinant growth hormone.
That's great. Have any families had success getting growth hormone by getting a secondary diagnosis of Prader-Willi-like syndrome?
I don't know. Maybe some of the, so they say yes. So you can see that, I mean, it's unfortunate, but obviously, those people who work for the insurance companies, many of them, have not studied medicine. A lot of people who have studied medicine have never heard of Prader-Willi syndrome. A lot of them have, let alone have heard of schaaf-yang syndrome. I mean, we cannot expect that they know about schaaf-yang syndrome. So it is actually, you have to play the system, and, sometimes it's certain trigger words which will kind of get you into one direction or the other. So if Prader-Willi is kind of, in their system and it's listed as an indication for growth hormone, then yes, Prader-Willi-like may help kind of get you onto that path.
Great. And I think we have one more growth hormone related question, which is if your child has been tested for growth hormone, falls in the typical range, is not deficient, is meeting milestones, should they still be pushed to be on growth hormone? Is there still a benefit for that individual?
So I think that's a clinical decision, right? I mean, every medication comes with side effects, and growth hormone has to be given as a daily injection. So it's not, it's not a lot of fun, especially in the beginning when you and your kid kind of get used to the procedure. Like once you've done it for a few weeks, nobody complains typically. But it has side effects, and I mentioned, the worsening of sleep apnea. It can also kind of affect insulin and glucose levels. And so if you don't see the need, then I don't think, there's if the clinical need doesn't exist, then, go without the growth hormone. Especially, I mean, if you mention that that child is meeting milestones appropriately, then it sounds like a relatively mild case of schaaf-yang syndrome, and growth hormone may not be needed. There's definitely a wide spectrum of schaaf-yang phenotypes. And you have all seen that in the Facebook group, and you've seen that at the family conferences. There are some kids who are fairly high functioning, who are in the borderline intellectual functioning range with IQs in the 70s, who may be able to go to regular school. And then on the other hand, on the other side of the spectrum, we have some kids who have IQs that are lower than 10, who are nonverbal even in their teenage years, who have a lot of complications. There's a wide spectrum, and I think depending on, this is a discussion that you need to have with your physician, whether there's really a need to treat or whether, you just do a watch and wait.
So growth hormone is recommended for adults with PWS. Is the same recommendation true for individuals with schaaf-yang?
So I would think so, and that's, I just say, watch and wait, because as I showed you, the clinical manifestations change over time. And as I showed you in some of the adults that we're in touch with, the obesity and the inactivity and also the osteoporosis become an issue. So growth hormone may help with most, if not all of those. Because it can decrease the adipose tissue, it can increase muscle mass, and as that increases, people become more active, and as they become more active, metabolism gets better. As they walk more, they're more out and about. It's good for the bones and the mineralization of bones, and so the osteoporosis may get less, so the bone health may improve. On the other hand, you need to keep an eye on the potential side effects. I mentioned the sleep apnea. What I've not mentioned is that in I want to say 2 kids in our study, the scoliosis also worsened as the kids were treated with growth hormone.
Mm-hmm. The scoliosis that worsened, was that during the teenage years when they were having a large growth spurt, and perhaps that would have been a confounding challenge?
Yeah, so I would need to go back in the data and see which patients those were exactly. But yes, it is something that, it's kind of like a question of is it really a side effect, or is it part of the beneficial effect of growing? I mean, we know that from Prader-Willi syndrome also, as they get into a growth spurt, then sometimes the scoliosis worsens.
Yeah, that is true. How about apnea? Apnea is a huge issue for our loved ones with schaaf-yang. If you have a child that has severe apnea, is growth hormone still appropriate? Is it going to worsen the apnea? Could it help the apnea?
Yes. It does not seem to improve the apnea. I mean, you could speculate that it might, because muscle tone improves, and sometimes when it's just obstructive sleep apnea, An improvement in muscle tone may improve the sleep apnea. But it seems, I don't think we've had much evidence of sleep apnea improving while on growth hormone therapy. Instead, in one kind of like 10% of children who are on recombinant growth hormone, it seems that the apnea has worsened. And I think there are some kids out there where the treatment with recombinant growth hormone was stopped because the apnea had worsened, and then the physicians kind of kept watching it, and then they were started again. But this requires a good interaction with your pediatric endocrinologist, ideally someone who's experienced with Prader-Willi, or someone who's experienced with schaaf-yang. A lot of the questions that relate to treatment with growth hormone, I forward to Jennifer Miller at the University of Florida in Gainesville, who's my to-go person when it comes to pediatric endocrinology. But also requires kind of good interaction, ideally at a tertiary children's hospital with a sleep specialist, neurologist, and pediatric endocrinologist, and then kind of bring them at the table and kind of discuss whether it's worth it. Oftentimes, it seems that severe sleep apnea is a contraindication for treatment with recombinant growth hormone. And those kids with mild or moderate sleep apnea, those are the ones who still get started.
So what do we know about apnea, and is there anything that our parents can do to help with that challenge? One of our parents states that they had surgery to remove the tonsils, and the sleep apnea is now worse rather than better. What can they do to help with that?
So unfortunately, I'm not an expert on sleep apnea. It does make perfect sense to remove the tonsils and the adenoids, because especially when it's heavy on the obstructive side, when tonsils are large or adenoids are large, that obstruction can decrease. Obviously, in some cases, it doesn't what we expect and what we hope for. But it's still something to be considered whenever there's an obstructive sleep apnea. Other than that, it seems to me that, in some way the kids grow out of it. So time sometimes, will be your savior. But also, I mean, if it's severe, then BiPAP or CPAP machines, may be considered. But I know it's a big struggle, I mean, for these kids, especially as it comes with the autism spectrum disorder and the cognitive impairment. So compliance is not great. The kids hate it. It kind of triggers their sensory issues, and it's a fight. It's not easy, but it's important to keep an eye on it, because I hate to say that, but looking at the many families we've been in touch with, there are obviously some who have lost their children with schaaf-yang syndrome. And it seems that apnea is one of the main causes of death. So it's something to be taken serious for sure.
Do we have any updated information on expected life expectancy for schaaf-yang people?
Yeah, so, in order to do that meaningfully, we just need more information on adults. I think at this point, the numbers are still too small for me to really make a statement that's based on evidence. I think it's clear to us that the overall life expectancy is decreased compared to the general population. Because we do see that, in part, depending on the mutation, there are some kids who die, even perinatally or in the neonatal phase. And then we've had some kids who we lost in their childhood years. I don't think I've heard of any adults in our cohort pass since we've been following them. So again, that may be in part evidence that, you know, the worst period is really kind of early childhood. And once the kids kind of get over that hump and things become a little more stable, their life expectancy may actually not be that bad.
We have a lot of rapamycin questions, so I think we're going to go into that area of questioning here. First question is safety profile. You mentioned that it's FDA approved for other indications. What is the safety profile of rapamycin, and would it be a long-term use drug, and is it safe for long-term use in people?
Mm-hmm. We will have to look into that once we start designing clinical trials. It's also a question whether we would use rapamycin itself. The brand name here is sirolimus, or if we would use a rapamycin ortholog, the brand name here is everolimus. They have slightly different safety profiles and side effects, but generally speaking, the main issue with rapamycin and the similar drugs is that they are immunosuppressant. This is how it was developed. You know, this was the intention of using rapamycin. It's used in transplantation medicine. After you were transplanted with an organ, it kind of decreases the likelihood of a immune reaction against the transplanted organ. But, you know, that being said, it kind of decreases your immune system. And that is, you know, one of the main issues to keep an eye on. So leukocyte count, etc. But there's safety data in adults and in children, and it is tolerated long-term. Also in those transplant patients, you know, they have to be given rapamycin over months and years. And I think the emerging data, for example, from tuberous sclerosis, it's the same thing. It's also long-term treatment, and it decreases the epilepsy and the seizure frequency over the long term. I would expect that in schaaf-yang syndrome also it needs to be given, you know, over the long term, because the way that I feel, you know, like when you think about what's wrong or what's going on in the brain of a child with schaaf-yang syndrome, if you consider your brain being a computer, so is it a hardware issue or is it a software issue? You know, I don't have much evidence that there's kind of miswiring or like really any regions in the brain that are malformed. The brains look pretty much normal. It's more on a molecular level. And we believe that it's an issue of what we consider neuronal homeostasis. So the ongoing function of the brain and the communication of the neurons. So with that, that's good, because that's our window of opportunity. You know, if it's more of a software issue, you can fix it. Hardware to rewire stuff, you know, we wouldn't be able to do. But because it's an ongoing issue, I don't think it's like you reboot the system and then it's done. I do think that you need to treat it continuously.
In the study with the mice, were you able to evaluate changes in sleep? Was there any improvement seen there?
No. So in this line of research, we are only looking at motor function and survival and body weight, grip strength, the performance on the treadmill. And we're now adding a line of research where we look at the ability of those mice to communicate. They don't really have speech, but they have ultrasonic vocalizations. So sounds that they make that they kind of the frequency of ultrasound, so we can't hear them, but they can hear, and we can make them be heard using special machines. So we can find out how they communicate with each other. So we're doing that, but we haven't done any studies on circadian rhythm and sleep in those.
Mm-hmm. From what you know about rapamycin and what you've seen in your study, Would you expect that rapamycin would have benefit for all ages, or do you think it would be more beneficial for a specific age group?
So I think that it may be beneficial for all ages. So again, like following my hypothesis of an alteration of neuronal homeostasis, I think you can treat at any time and still see benefits. I don't think that, it will be a cure for schaaf-yang syndrome. I don't think that schaaf-yang syndrome will go away. But I do believe that there's hope that it may treat and improve some of the manifestations and phenotypes. We're doing actually two studies. We are looking at mice where we start treatment after birth, and that's the data that I showed. But we also do a study where we give the rapamycin to the pregnant mothers to see, because we know that there's also perinatal death of those mice. And we're looking to find out if we can rescue their survival by treating the moms. The data are not completed yet, but I'm not entirely hopeful that it will rescue that phenotype. But there are some challenges because the perinatal death occurs not that frequently, so you need to look at many mice to see if it has an effect. Now, in addition, because of those first results that I showed you, we're also starting a study where we start treating those mice much later. These mice that I showed you, we started on day of life 10, I think. And now we're doing a study where we let them age for a while, and then we start the rapamycin treatment to find out if it still has a beneficial effect. And also if a short-term treatment has a beneficial effect, or if you really treat, if you really need to treat over weeks and months.
So when do we have a time frame for when this study that you've discussed will be published?
It's hard to tell. There have been delays because of COVID, actually, because especially during the first wave, the research laboratories were completely shut down, and just like many of you were in your home office, like we can't do any mouse work in our home office. Would be kind of nice and cute to have the mice on the treadmill at home. But those genetically manipulated mice, they're in a very kind of safe environment that's very clean, and so we actually had to stop a lot of our experiments, which is not just a delay for the time that the lab is shut down, but when you reopen the lab, you need to start breeding the mice again, and they have to age again. And so it certainly caused a delay of almost a year. We're continuing those studies and doing as much as we can. Ultimately, the question, when will it be published, is not just in our hands, but as always, when it comes to peer-reviewed publications, depends on the journal editor, the reviewers, how many questions they have, if they force us to do additional experiments. Sometimes that's a process of 3 months. Sometimes it's a process of another year. It's in my interest and in your interest that we get this information out sooner rather than later, because it will be the basis for discussions to think about clinical trials in individuals with schaaf-yang syndrome. But that won't be easy either, because what's easy in mice is we can generate as many mice as we want, as long as our ethics committee allows us to do that. And they all, brothers and sisters or cousins, and they all at the same age, and we breed them so that they're ready at day 14, day 10. They get rapamycin. They all started on the treadmill on day 84. It's much harder when we do that with real people, because some of your kids are 5 months old, 3 years old, 17 years old. And obviously a 5-month-old kid does things very differently compared to a 17-year-old kid. So we will need to discuss what are our outcome measures, what can we quantify, and obviously we want to do a blinded study, a placebo-controlled study. So we need a reasonable number of individuals, and we need good quantifiable outcome measures, so that we have the best chance of making this clinical trial a success.
So clearly there's a lot of excitement, I think, from our families around this as a potential concrete next steps. What do you need funding for next so that you can continue to move this forward?
So I think, we just got another study published by FPWR in the last round. Thank you. That study will actually look at oxytocin in astrocytes in the brain of mice and schaaf-yang syndrome. Will be more relevant towards the autism research. But no question, we're continuing those rapamycin studies at full speed. I have institutional funding to support that. I have postdocs and students working on that. Once we get ready to consider clinical trials, that's when it gets expensive again. And at that point, we will write grant applications, or, sometimes the families or the family support organizations feel that something is so important to them that they don't want us to go through the regular round of application and review, but that they say, well, we just want this study in particular, and we will raise money, not, for an open call of proposals, but we'll raise money for that particular cause. And if that's what you want, I will get down with clinical trialists to discuss, what's needed. I think we would definitely design that as a trial that has at least 2 study sites, one likely here in Heidelberg in Germany, but also a study site in the United States. And we will most likely design it as a trial where you can give the rapamycin at home, but then come back to the study site at various time points to do standardized assessments. We will kind of sit down and make a plan and come up with a budget, and we'll make it happen.
Great. Just to be clear, so when families are when families are fundraising or donating for schaaf-yang syndrome, FPWR does earmark all of those funds, and that's how we've been able to be funding these studies that Dr. Schaaf has been discussing today. And we will share some more of that information. I made a note to myself to send out some of that information about what has been funded off to the Facebook group, so you guys can see some of that. But again, all of your fundraising efforts, we track them all for schaaf-yang so that we can make sure that we're funding a specific schaaf-yang project every year. So it's great to know kind of what's coming up the pipeline, Dr. Schaaf, so that we know what we'll be seeing from you next. All right, I've got, again, a lot of questions in here. I know there was one in here about osteoporosis, and you mentioned that growth hormone might be able to help with osteoporosis. Are there other treatments that should be considered for the treatment of osteoporosis and perhaps strengthening the bones?
Yes. When you do x-rays or DEXA scans typically can only be done when the kid is at least 5 years old. But you can do x-rays of the hands and get an appreciation of osteoporosis even earlier than that. That's the first indicator. When there is osteoporosis, you should definitely check vitamin B levels, calcium and phosphorus levels, and you should improve vitamin D intake as much as you can. So, many of us do not have vitamin D deficiency, but many of us have vitamin D insufficiency. We have decreased levels of vitamin D. It's not that severe that it's a deficiency, but it's in the low normal range or outside of the normal range. And that's, true for many of us in the Western world, especially during fall and winter. It gets worse during fall and winter. And it's just because we spend way too much time inside and we don't get enough UV exposure. And so vitamin D production, like in the body, is down. Optimize vitamin D levels, and I would definitely recommend to keep the vitamin D levels in your children in the mid to high normal range. Also, calcium intake. Vitamin D can only do its job when there's enough calcium supplied. So also optimize calcium intake. If it gets worse, then there are other options. So obviously, just like for osteoporosis, there are the bisphosphonates, which can be taken orally or by injection. There are different classes of bisphosphonates when there's true osteoporosis. Meaning a decreased bone mineral density that's lower than -3 standard deviations, then you should start a discussion about bisphosphonate treatment. There may be even better, even more specific treatments for osteoporosis in Prader-Willi syndrome and schaaf-yang syndrome. There's a group in Israel that published a study, I want to say a year or two ago, about oleoyl serine, which is a specific metabolic compound that affects the function of the osteoblasts and osteoclasts and improves the mineralization of bone in a Majel-2 mouse model. But as far as I know, that's not an approved medication at this point, so it's still experimental. But there are multiple options.
Thank you. A lot of questions about genetic therapies. Do you have any insight as to the potential of reactivating the maternal gene or replacing the Majel-2 gene as a transformative treatment for schaaf-yang?
Yes, so there are ongoing studies. Marnie Blewett, who's an investigator in Australia, is really leading some of those efforts. And we've been collaborating with her. In fact, one of her PhD students was visiting in our lab for three months just prior to COVID. She was here with us to work on the induced pluripotent stem cells. And we shared some of those cells with that group in Australia, and they're trying to come up with ways to reactivate the maternal allele of Majel-2. So some of that work is ongoing, and I'm very excited about it and looking forward to hearing about their results. I do know that Marnie is presenting at the research conference later today.
We have questions about the oxytocin study you mentioned. Can you share any information about what that will be?
We do know that oxytocin function and maybe oxytocin levels are decreased in Prader-Willi syndrome brains. And that may also be true. I expect it to be true for schaaf-yang syndrome as well. We are studying, this is a more kind of basic science research study. There's a very talented postdoc who's joining my lab from Atlanta in the beginning of next year, who has a lot of experience with oxytocin and does very exciting kind of imaging work of neurons in the brain. And he's investigating the role of astrocytes, which is a specific cell type in the brain as it relates to oxytocin function in Majel-2 and Prader-Willi syndrome. Now, oxytocin, is of interest because it's a hormone that affects our social interactions, and there's been a lot of interest in oxytocin. In the Prader-Willi community, you can give oxytocin as a nasal spray, and that may improve some of the PWS and maybe SYS related phenotypes. So it did have an effect on feeding behavior in the neonates, and it may also have an effect on kind of social interaction.
we have some more questions about rapamycin, so I'm going to swing us back to that topic for just a minute. It's commented that it seems like a lot of kids with schaaf-yang have epilepsy. Could this possibly be caused by the excess mTOR? And do you hypothesize that rapamycin would potentially treat that epilepsy as well?
Yeah, so this is speculation at this point. I feel that maybe 20% of kids with schaaf-yang have epilepsy. Now, what we know about tuberous sclerosis and some other neurodevelopmental disorders, yes, some of these have much higher prevalence of epilepsy, and it has been shown that mTOR is upregulated and rapamycin can treat it and decrease seizure frequency. So that may well be true for schaaf-yang syndrome as well. I mean, it's certainly a good hypothesis.
All right. So we've talked about rapamycin a lot. You mentioned oxytocin. Are there any other treatments that are perhaps in the hopper that are being considered?
These are the ones that we're kind of following up in my lab at this point. But I know there are, several other labs working on MAGEL2 and Prader-Willi syndrome. It has been a little more challenging to keep in touch with all of these wonderful people. There are lots of talented researchers in the field, but it has been a little more challenging during the pandemic. So it's one of the reasons why I also kind of look forward to next year's conference, because typically, a day before we have like a half day where all the people who work on MAGEL2 and schaaf-yang syndrome kind of sit together and discuss, what we work on. I'm in touch with some of them on a regular basis, but I don't think I have like a full appreciation of everything that's going on. And also in my lab, I think there's a lot of value in focusing on some particular aspects and doing things right and carefully and thoroughly, rather than doing too many things at the same time. And I think the rapamycin story is quite promising and something that we should really focus on at this time.
Mm-hmm. That's great. You mentioned the conference. We are hosting an in-person conference, fingers crossed, in Chicago, October next year. So the dates are going to be September 30th and October 1st. We will have some schaaf-yang specific sessions, as well as our standard Prader-Willi sessions. And again, our schaaf-yang families are more than welcome to attend all the sessions of that conference. There's so much overlap, as Dr. Schaaf has presented today, in Prader-Willi and schaaf-yang, that really most of these sessions will be very relevant to both groups of people. All right, here's a question about family planning. We know that the father can be a carrier for schaaf-yang. Is there any advice for family planning to prevent having additional children with the mutation?
So if you have a child with schaaf-yang syndrome, then the dad should be tested. So a blood sample is taken from the father, and it's looked at whether he's a carrier of the MAGEL2 mutation. If he is, then there's a 50% chance for every future child to be affected with schaaf-yang syndrome. So that would be an indication definitely for prenatal testing. And if the child is affected, depending on your beliefs and your approach, termination of the pregnancy obviously is an issue, or is a consideration. But also if dad is a carrier, that would also be an indication to consider pre-implantation genetic testing. Which is an option both in the US and also in Europe. This would mean that you would not conceive naturally, but you would conceive in vitro. And then the embryos that develop are separated from one another. And there is one cell or a couple of cells taken from each embryo. They are tested to find out if they carry the MAGEL2 mutation, and only embryos that do not carry the mutation would be implanted. If dad does not carry the mutation in his blood, then the chance of having another child with schaaf-yang syndrome goes way down. It never goes to zero. Nothing is zero in medicine, but it comes down from 50% to less than 2%. It's still increased compared to the general population because there is a chance of having a so-called germline mosaicism. This means the mutation is not in every cell of the body, and the mutation is not found in the blood. But the mutation occurred in the germ cells, meaning the testicles, at some point, and that there's a subset of sperm that carries the mutation. This is not frequently the cause, but we have a few families where the dad did not have the mutation in the blood and still they had more than one child with schaaf-yang syndrome. Now, this would not be considered an indicator, that small risk of less than 2%, which sounds high, but on the other hand means greater than 98% not affected with schaaf-yang syndrome. That would not be considered an indication for pre-implantation genetic testing, but it would still be an indication for prenatal testing. So every family who's had a child with schaaf-yang syndrome should consider prenatal molecular testing for the familial MAGEL2 mutation. But then, you know, if you do that, you're still left, and if unfortunately the child carries the mutation, you're still left with that very difficult decision of whether to terminate the pregnancy or not.
Okay, tough decisions. How about, let's talk a little bit about COVID. Are there any concerns about challenges that individuals with schaaf-yang have that might prevent giving them the COVID vaccine?
I don't think so. In contrast, I would say I've been very concerned about our schaaf-yang kids during the COVID pandemic. Because just like I showed you, a lot of these kids have respiratory issues. And we know from many of you that, you know, during flu season, RSV season, a lot of your kids end up in the hospital because when they get respiratory infections, they just so much more severe, and their oxygen saturations go down and they have like severe breathing difficulties. So I would consider every child with schaaf-yang syndrome a high-risk patient when it comes to respiratory issues. So that being said, I would actually argue when the vaccine becomes available to you to strongly consider vaccinating your child.
Thank you for that information. That's wonderful. We have a question about contractures. Do you have experience with patients having knee contractures, and how effective has serial casting been for treating that?
Yeah. So as I mentioned, you know, the small finger joints are the most commonly affected, but in some of the more severe cases, we've also seen elbows and or knees being affected. You know, the challenge is, I mean, in part it's like a bony issue, but in part it's also a tendon issue because the tendons are shortened because that joint has never been fully extended. So physical therapy is an absolute mainstay, but when that is not enough, casting may help.
Thank you. Going back to family planning, should siblings of individuals with schaaf-yang have any testing? Is there any concern there that they should have when they're planning for their families?
No. So the siblings of a carrier father, they should be tested. But if you have, as a couple, have children with schaaf-yang syndrome, then the mutation is either de novo or it comes from dad. So all of those children who carry the mutation should be clinically affected. If you have children who are clinically unaffected, you don't need to test them.
All right. We have two questions regarding GI. I'm not sure if that is your expertise, but perhaps you could shed some light. Is constipation common? And if so, what's the cause and what can be done to help address that?
Yeah, constipation is common. So, there are multiple GI issues in schaaf-yang syndrome, starting in the upper GI tract with the swallowing difficulties, and then all the way to the bottom with constipation. We do know that constipation is more common in children with autism spectrum disorder compared to neurotypical children. So it may not be schaaf-yang specific. But we also know that schaaf-yang affects the musculature, and it may also affect the smooth muscles in the GI tract, and may slow things down. So I do believe that a fiber-rich diet is helpful. And if that's not enough, I would definitely consider something like Miralax, which I feel is a medication that's easy to handle, that's well tolerated, can be titrated up and down. If stool is too hard, you give more. If it becomes too thin, you go down again. I've given it to children as young as 2 months, 4 months old, and the oldest patient, not with schaaf-yang, but oldest patient I've treated with Miralax was 104 years old. It's an easy medication, easier than other laxatives, I think.
We could probably talk about behaviors and medications in a whole nother presentation, but I feel like we do need to try to address a couple questions that came in. Are there any special considerations when parents are looking at behavior medications for their loved ones with schaaf-yang? I know in Prader-Willi syndrome, some medications work better than others. We have a motto to always start slow and low and slowly titrate up because our kids seem to be very sensitive to drugs. How does that work with schaaf-yang families?
This is probably one of the most challenging aspects when it comes to like symptoms and treatment, because there's so many antipsychotic drugs out there, and none of them work great, and they all have like their own profile of side effects. So I'm entirely with you, Susan. This should be in the hands of an experienced child psychiatrist, someone who's experienced with special needs children. And the motto of kind of starting slow and low, and then kind of moving your way up into it, is the paradigm that you should follow. But there doesn't seem to be a magic bullet here. One of the main issues, it seems, is anxiety. I do see a lot of anxiety in those kids.
Yeah. So, for all of you who do or do not know me, my child has Prader-Willi syndrome, and he does have anxiety. He does have behavior challenges. My advice to all parents is to build a relationship with a psychiatrist early on, so that you have that relationship, you can talk with that person, and as behaviors change, you can have discussions about appropriate medications. When looking for a psychiatrist to help you, my suggestion is find someone who's willing to work with you and is willing to review publications that are relevant to schaaf-yang and Prader-Willi, because our kids are slightly different. They do have innuendo to this, and to their symptoms, and having someone that will listen and work with you rather than have the one size fits all approach is really important. Again, we could probably spend hours talking about just that, but I do want to be respectful of the time. It's now 1/2 the hour. So I'm going to go ahead and wrap this up. Dr. Schaaf, I know you're available to families. So if they have more questions, is there a contact that they could reach out to?
Yes, so I would think that most of you are already in touch with me. You can always send me an email. Email is usually the easiest. And I have several email addresses, but the easiest is still the Baylor address. It's schaaf@bcm.edu. So feel free to email me and we'll get in touch with you. Another way is through Facebook. I'm part of the schaaf-yang closed family group. I'm not supposed to answer any medical questions there, but you can send me a message and then I will kind of, send you off to my email address. Thank you all for listening. It has gotten dark out here. I'm heading home to meet my family. And then tomorrow morning, I'm getting up, fresh and early because my train is leaving at 7 a.m. to go to the annual in-person meeting of the German Society of Prader-Willi Syndrome, which is taking part this weekend in Bonn. So I'll be giving a talk there and meet families there.